cosmosis, and speech and swallowing impairment, and speech impairment, and also hearing impairment worsens their quality of life. Thus each and every part of this has to be addressed to reduce and optimize these functions in these individuals. So rehabilitation after surgical and reconstruction after head and neck cancer requires that speech and swallowing therapist as well as rehabilitation should together work together in making this patient journey very fruitful. So where disease and treatment has both effects on swallowing dysfunction, and where this disease and as well as the treatment will reduces the oral control, and it improves the and decreases the swallowing dysfunction, and safety and as well as the efficiency of the swallow is decreased. So understanding these factors are important before initiating the speech and swallowing therapy. So as a role of speech and swallowing therapy, so I'll be having safe swallowing strategies initiation to avoid the aspiration, to therapeutic postures and exercises that I will be initiating the patient, and modifying the diet. These are the three major differences that I will be bringing in the swallowing therapy. So moving to the signs and symptoms of the treatment. So its cardinal symptoms are cough, fever, and weight loss. We need to check before that triggers for the evaluation of dysphagia. So moving to the clinical dysphagia evaluation, so I begin with the evaluation of reviewing the chart, where is the site of lesion, what is the type of surgery, extent of surgery, and overall clinical status of the patient, whether the patient is fit for evaluation, and then moving further to the oromotor examination and cranial nerve examination and of all the structures that are useful for swallowing, in which oral hygiene is a paramount importance before the initiation of the speech and swallowing therapy evaluation. So moving to the water swallow test. So water swallow test is an important clinical tool to identify and screen the patient with the speech and swallowing difficulty. So I'd like to show a small video sample of a patient performing 100 ml water swallow test. So 100 ml of water bolus is given to the patient, and the clinician is observing the movements of the larynx, and upward movement of the larynx indicates the laryngeal elevation, which to see the intactness of the integrity of the structures for swallowing function. The patient's taking quite long time to continue to swallow. I think the video does not have an audio or something. The patient has the evident symptom of throat clearing, and then the clinician is asking the patient if any other issues the patient is facing after the swallowing. The patient is reporting that there is only a mild difficulty that he is noting. So such evaluations will help us understand and what could be the possible problem the patient is facing. So with this simple clinical tool, we can proceed further. So I'm evaluating whether the patient has any defects in the tongue, as well as the elevation of soft palate, which make me understand whether any nasal regurgitation is occurring or not. Okay, thank you. Next, coming to the water swallow test, it has advantages and disadvantages, where it has a fast, easy, and reliable, validated method. But disadvantage of this is a silent aspiration, which cannot be identified in this water swallow test. So, and also it also unable to identify what could be the possible pathophysiology, which we won't be able to visualize it. So once we perform this, what is the next thing that we need to do is, it is not just enough only with understanding the patient is having problem or not, but where is the problem, how is the problem. So understanding that, so we need to generate a hypothesis of what could be the possible pathophysiological problems the patient is having, and how to do it by doing an objective evaluation. So before going to the objective evaluation, what are the possible hypothesis generation is that this patient might be having, that this is very adequate. I understand that inadequate lip closure, reduced base of tongue, patient may be having any problem with respect to safety issues, that is reduced epiglottic closure or vestibular closure, or and reduced piriform sinus opening leading to the spillage. So all of these factors could be contributing to any of this physiology, which we won't be able to understand by only performing clinical swallow examination. That's why we may require either video fluoroscopy or endoscopic evaluation of swallowing to understand all of these things to tailor the therapy. So we need this objective evaluation, as it has been cited that the patients are aspiration are undetected in their early phases. That this will help us to understand which patients will require more advanced treatment and more tailored approach. So in predictors of aspiration pneumonia, mostly it is cited that oral hygiene has been a common cause for development of pneumonia in these patients. So thus, as a speech and swallowing therapist, my utmost and prayer in evaluation is checking for their oral cavity examination and presence or absence of the oral hygiene and promoting the oral hygiene in these individuals. So the patient is tracheostomized, and it is quite possible to understand the silent respiration, and we can use it with modified Evans blue dye test. So by adding a small water dye along with the food color, it will help us to understand while performing a water solid test, and with the help of suction or sputum, we will be able to identify if there is any sputum coated with the dye is having any silent aspiration or not. So silent aspiration is commonly that we understand that absence of cough is not equal to absence of aspiration. Thus, having an instrumental evaluation in these patients will help us understand to rule out all this silent aspiration. So after completing that, we need to answer ourselves for all of these questions, whether there are any symptoms and pathophysiology, as well as the decision making for removal of feeding tube, or should we increase it for orally, or improvement in food consistencies. So general summary of the swallowing summary is to identify the pathophysiology and effective strategies of the treatment that we selected for the patient, and what is the treatment plan given to the patient. And for communicating within the across the domains, so we need to have different outcome measures that usually generally used across all the centers, and which can be used among oncologists as well as speech and therapists or any other medical profession, which can be used to collect the information of the swallowing status of the patient by reporting of the water solid test, the performance of it, and functional oral scale, and performance status as hair and neck cancer scale. We'll just see in next slide. So functional oral scale, it is a simple scale that has developed, and with this level of oral intake can be understood by just rating the level of anywhere between 1 to 7, 1 being nothing by mouth, where 7 being total oral diet with no restrictions. And second scale that we use is performance status scale, where in which it is similar scale where it talks more about the consistency the patient has. Also a component of that, it has understandability of speech anywhere between 0 to 100 or anywhere 0 to 100 for diet. Talks about the consistency patient is safe to initiate or to document for the communication. And time points of care for SLP. So as it is mentioned in the literature that there is a different phase of recovery. So where speech therapist or a swallowing therapist should be engaged all of these phases for optimizing the function. So of course, a VT radiotherapy review is mandatory in all its patients to understand this and monitor the swallowing status. And diet modification. So as a speech and therapist, we assess and identify the possible and safe diet the patient can be initiated, and based on the weight as well as this clinical swallows performance. So for the dietitian, this particular FOI score or PSNH score is necessary for them to advise type of diet in their advice. So proactive speech therapy is very, very essential in engagement of this good speech and swallowing therapy in all these patients for improvement in their swallowing function. 6 is of course good intervention requires good evaluation. Completing the evaluation, starting the rehabilitation strategies. So we all understand that all individuals will require different type of strategies that we can give to the patient, wherein which exercising the patient, giving with various types of maneuvers as well as the compensatory strategies will help and improve the muscles are involved in the swallowing. So I'd like to show another video of small postal modification individuals who underwent a case of buccal mucosa who underwent surgery, where the patient has inadequate lip seal. So he is simply applying a finger pressure over the labial seal, and which thereby reducing the labial seal and incompetence. And in another case, the patient is trying to swallow, and you can observe that very clearly. In the neutral posture, patient has evident anterior spoilage. So in a reclined posture, this has been effectively reduced. So such strategies can be employed easily in the clinical setting and teach the patient to initiate the oral trials. So another case example, which is an image of video fluoroscopy, when the patient using a head back posture to easily propel the bolus for easy initiation of the swallow. And some more case examples I would like to give. So in swallowing rehab in oral cancer, patient who underwent anterior tongue, and who in such patients what we have to do, waiting for a few more days and initiating oral trials after 7 days, and we can initiate with modified water soluble test, and after that the patient seeing the status, how the patient is improving, based on that we can initiate further more trials. And next, moving to the other complex cases, so in such situations wherein which considering of healing issues and seeing whether coordination between the speech therapist as well as surgeon is essential in managing such patients. I'd like to show another case example wherein which in patient who underwent bite composite resection with hemimandibulectomy, after the surgery, almost after 6 months, the patient's status is having severe aspiration and dysphagia, and with continued therapy into 2025, that is almost 20 months later, the patients after radiation therapy, after improvement with post radiation therapy, some symptoms and surgical symptoms with edema, and with improved efficiency and safety, the patient swallowed. So with that, swallowing exercise plays a major role in these patients, wherein which both active and passive management of should be done in these patients. We'll focus more on further things in next subsequent sessions, wherein which the patient's exercise to be taught, range of motion exercises, tongue range of motion, labels range of motion exercises to be taught, and different maneuvers with effortful swallow and mesohypo maneuver to improve the strength of the tongue. And with other devices such as jaw stretchers can be used in management of trismus. And other role we have, even in palliative patients also, there are certain roles for speech therapists in which we can try to reduce the symptom of the patient by supporting to palliative rehabilitation and closing the episodes of care in such situations. Okay, in summary, just last slide, sir. So, in principles of swallowing rehabilitation, evaluation, patient education, modification of diet, educating compensatory strategies, and swallowing exercises and clinical nutrition consultations are very much essential in dealing with these patients. So, I conclude with that partnership essential with being a speech therapist as well as all oncological fields in managing these patients. Thank you very much.